welcome to the part 2 of the case sheet tutorial. I'm going to go through an exemplar here that I've got up for you guys. Just be aware that when you work for an ambulance service, case sheets are a lot more extensive. They have a lot more different sections that you sometimes have to complete. So what we've tried to do is kind of simplify it for your CLS204 with some of the main components that you will be covering. So I'm going to go through it step by step to give you an insight of why things are in there and why it's important to document things in a particular way. And hopefully it will just bring a lot of clarity when you start to use these case sheets and complete them as well. So just to start off with, your incident details, that's the first line. And the first box you'll often have is your time of call. Now, it's always important when you get a job to look at the time of call, because if it's a really busy night, you may, for example, get sent to an elderly person that's fallen, and the time of call is 1 o'clock, but you were actually assigned at 2 o'clock. So you know that patient has been already on the floor for an hour. So sometimes you get some red flags, even just from getting a bit of that information when you look at the job that you've received. So always look at your time of call. You should be mobilizing, so accepting that job straight away. It shouldn't take really any longer than 10 seconds. If you are kind of, if you decide to finish your lunch or go to the bathroom and you haven't actually mobilized, then you will have control contacting you, asking you why you haven't mobilized. And the justification that you give will be documented in the notes, because we're under a lot of pressure as paramedics. I completely understand, but the control room is as well, and they have to meet certain targets and KPIs. So we both have to work as a team to do the best that we can for our patients. Then your on scene is obviously when you've arrived, when you depart scene. If you take the patient to hospital, your time or arrival at hospital, the date of the job, the ethnic code, and the hospital code. Now, the hospital code will very much depend on the area that you're working, but the service will provide you with all the codes in the state or the area that you're working in, because sometimes you're out of area. The ethnic code's really important, because with the ethnic code, what the ambulance service does is when it starts to audit your patient report forms, it can start to pick up on trends and patterns amongst certain ethnicities or communities, and that helps us improve some of our guidelines or protocols for better care. So that's why sometimes you get an ethnic code. And again, the codes associated with the different ethnicities will be provided by the service that you're with. Your patient name, middle name and surname, obviously that's just as it's given, but always make sure that it is the patient's name, because sometimes people have a nickname or other names that they go by. So it's just making sure you've got their legal name, their address, and their incident address. Now, you might go to someone outdoors, so you want to also make sure that you've got the patient's home address, and you'll document the incident address as well. The age of the patient and their date of birth. Just a really good tip, always ask them for their for their age first, and then their date of birth, because when you ask them for their date of birth, they'll tell you to just work out their age. And then their gender. Now, the really good thing about the first line, which is the incident details, is that generally your MDT within the ambulance, which is where you get all the information about the job, and also the radios provide you with a lot of that information and keep track. So if you had forgotten to write down your on-scene time, you can go back and have a look at it. But in terms of record keeping and timekeeping, that is the only thing that it records. So any other times of observations, assessments, mental capacity assessments, all of those things are reliant on the paramedic to record. And obviously, if your information isn't clear, accurate, and factual, then one, auditing will probably pick that up, and that might come back as a problem with your documentation. And two, if any of your job goes to coroner, or anyone needs to look at it for further information regarding that job, because you might get a complaint or whatever it might be, then a lot can be said about the way that paramedics document. So it's important that You do thorough assessments and you document everything that you've done. Now, there'll be a section on writing your observations. You always write the observations and always write the time that you started. So just say I did a heart rate, a blood pressure, and a rest rate, and then 10 minutes later I did a blood glucose level, then that blood glucose level would fall under a second set of observations, because it doesn't take 10 minutes to complete a full set. In a really kind of stable patient, you may conduct your observations approximately every 15 minutes. However, it very much depends on how long, obviously, the condition of the patient, how long you're on scene for, and other things around that. Always make sure that before you, refer a patient or before you arrive to hospital, that your last set of observations were conducted within that 5-minute period. But in terms of how often you assess someone, that's also going to differ, because you might have someone with low glucose levels that you'll be assessing a lot more regularly. You might have someone else that you're continuously assessing and monitoring. So again, it's very much dependent on what you're presented with. The observations in the report forms may also include things like ETCO2 readings and peak flow. So like I said, I've just kind of picked the baseline obs that you guys will be really familiar with at the moment. Your medication section here, that is the medication that you, or the treatment that you give to a patient. So as you can see a bit further down on the interventions, that we cannulated this patient. It only took us one attempt. So we cannulated around 1406, and I gave the flush sodium chloride at 1405, and I gave the sodium chloride flush at 1406. Now, so you write the drug name, write the full name of the drug, the route of administration, is it IV, IM, IO, oral, subcut, whatever it might be, and then the dose of the drug. Now, with the dose, sodium chloride, it's 10 ml, but for example, if you were going to give a drug and it was 4 milligrams in 2 ml, the dose of the drug is the 4 milligrams. So some drugs are remade with, made up with additional saline, but you want to actually put the dose of the drug you've given. So that's really important as well. Protocols, what guidelines you used. Obviously, a part of the service that you're in, you'll be able to document the guidelines that you have used, and the patient transport to your local hospital. So you wouldn't put local hospital, you'd actually write patient was transported to RPA. Your interventions here, so where we've gained IV access, it's important to put the number of attempts. Again, different services have different protocols. So in some services where paramedics can IO patients, they'll say a minimum of 3 attempts IV would have to be attempted. So it gives that indication. Also, if the patient is, if we've attempted 3 times, it may also give us an indication of how shut down that patient was. So it's not about, often people worry about recording this stuff, but it's really important because it kind of gives as much information about the job. Notice here as well, normally when we cannulate, we always have to cannulate for a purpose. So in this incident, we haven't given any drug or pain relief or anything, but we have cannulated. So in your section below, it's something that you probably want to mention, the purpose of why you cannulated but haven't given a drug. So it might be because the patient has clearly had a seizure and they were showing signs of potentially having another seizure, whatever it might be, then also make sure that that's included. Now, I'm not going to go through and read every single line, but as you can see, the presenting complaint here, we've been sent to someone who's had an episode of loss of consciousness, and it was a query seizure. So, like we said, if you get there and the patient's like, I've got chest pain, headache, that's your presenting complaint. But if we've got things like where someone's witnessed a seizure, then always put query and then explain it in more detail in the history of presenting complaint. So the history here was patient was walking to the lunchroom when he began to feel lightheaded and dizzy, witnessed to collapse by a first aider on the floor with an episode of loss of consciousness. Witness to the event says he began to fit for approximately 10 to 20 seconds, query a seizure. So you're describing and you're giving all the information of what happened prior to you arriving from the patient and from any bystanders that were around as well. On examination, I said it's always good to start with on arrival and your general impression. So here we've got patient sitting unassisted and upright on the couch. General impression, patient is alert, good work of breathing and slightly pale. On examination, as I said before, it's always good just to give you structure. Start with your primary survey. And then go on to your assessment. So here we've got airway, breathing, circulation and what they found. The environment, so as well. So even though you've done airway, breathing, circulation, disability, also mention the environment and whether there was any concerns with it. Any anomalies with your observations. So here we've got vital observations identified, increased rest rate. However, patient completing full sentences and is not complaining of difficulty in breathing. Cardiorespiratory assessment. Now I haven't written the whole respiratory assessment out, but you would, because you've got a collapse query cause, you're probably going to do a cardiorespiratory assessment and a neuro assessment. So in this section, you would probably want to talk about weight or body, hands and nails, face and eyes, neck, if there's an increased JVP, then you would also go on to do inspect, palpate, percuss and auscultate. So I put that there as what you would talk about, but obviously in your report form, you would talk about any findings in those assessments. And if things are normal, then you write that they're normal as well. Bradycardia confirmed with 12-lead ECG, new onset or query new onset. So if the patient says, I don't know what my heart rate normally is, then it's a query, right? Because his heart rate might be normal for him. We've got nothing to compare it to. So that would be a query onset. Also, we've identified that the patient is hypoglycemic and he's been treated on scene with food. A rapid trauma assessment was conducted. So I've given an example here where I've put contusion to the right side of the head, query post-fall, because the patient was unsure whether it was present before or not. And then I've also written what I haven't found, like no neck pain or visible injuries, no chest pain or visible injuries, no abdominal pain, no pelvic pain, and so forth. So it's important to write what you find and what you don't find as well. And then I've also gone on here to do a neurological assessment, and this is where you would include your AEIO tips, your FAST, cognitive function, your cerebellar function and coordination, your cranial nerve results, and peripheral nervous system examination. So you can imagine already your on examination is really extensive. Obviously, this is a summary of what you need to include for this type of job, but when you're actually writing out all your findings and what you haven't found, it's going to be quite extensive. We've also written here that a postural blood pressure was undertaken, and then you start to also think about trends, patterns, deteriorations, and improvements. So here we've documented that the patient's blood glucose levels had improved post the food that he was given on scene. So when you go to a patient and you're like this, you've got collapse, query cause, query seizure, you are thinking about your primary survey, you're thinking about your vital steps of vital observations, you're also thinking about secondary survey or rapid trauma assessment, you're going to be thinking about doing a cardiorespiratory assessment, and you're also going to be considering doing a neurological assessment, because has he collapsed because he's bradycardic? Has he collapsed because he's hypoglycemic? Has he collapsed because he's got postural hypertension? Is there potentially an arrhythmia that we haven't picked up? So to cover all your bases as a paramedic, these are all the types of things you would include. So your free text here would actually be very extensive. So in some of it, I've tried to show you how you would write it. In some areas, I've said this is what you need to include. Obviously, you wouldn't just list what the neurological assessment is. You'd actually write about your AEIO tips and if anything was positive or negative. Past medical history, which is just the patient's medical history, medications. It's always good to write the name of the medication, the dose, and how the medications are given. So for example, you get into some patients and all the medications are in a blister pack, or some are just scattered everywhere in a box. Always kind of write where those medications are kept and how often they take it and the dose that they take it in, which is really good practice. Allergies, again, if it's no known drug allergies, you just record it as NKDA. Social history, so for this chap, we've got smoker, half a pack since he was 16. He has alcohol approximately 6 to 12 drinks per day. So again, it's just giving more information about that patient's social history. He lives at home with his wife, he doesn't exercise regularly, and so forth. Family history here, the patient's father and mother had deceased at the age of 58, 59 from myocardial infarction. So that's a red flag. So you've got a patient who's collapsed query cause, query seizure, and he's also got a history of myocardial infarction in his family. So it might be that he's had a syncopal episode, and he may have been hypoxic at that episode, which has caused him to have that seizure for that 10 or 20 seconds. So you start to look at primary and secondary potential causes. His treatment was, we made him a jam sandwich at home to treat the hypoglycemia. He was transported to the hospital via ambulance for further diagnosis and assessment of injuries. And then you'd put your provisional diagnosis as well. So, query syncopal episode, query seizure, query hypoglycemic. You may have 1, 2, or 3. You might have a primary one, a secondary one as well. So you might say query seizure, secondary, or to X, Y, and Z. And then your disposition is where you finally transported that patient to. And then you make sure that you always have to sign and date your patient report form at the end. So hopefully that gives you a little bit of context. Like I was saying, for the purpose of this, the detail in the on examination and in the free text is, it looks like it's not a lot, but obviously when you're conducting all these assessments, you're going to be writing about all of them. So they are normally really, really extensive. And a lot of report forms will even remind you of the chronological order in which you write. So it's always the presenting complaint and then the history and then the on examination. So we don't start with on examination or past medical history. So make sure that, again, it follows that chronological order. So that's kind of the example about patient report form. Obviously, if there's anything that you need further clarity on, then don't hesitate to contact me. And it does take a bit of practice using medical terminology and writing in a way that's very clear and refined without having to kind of waffle or use certain words. So don't worry, it's just you've got to keep practicing. One thing I was going to say as well is, that on the side here I've put PC, HPC, OA, OE for the subheadings. That's fine to abbreviate it. But when you're talking about a medical concern, then make sure that you use the medical terminology in its full context in the writing, because medical abbreviations sometimes have an abbreviation in medicine can sometimes have 3 or 4 meanings or conditions. So make sure that in the free text, when you're talking about a medical problem or a medication that you gave, that you're writing the full name of it and you're not abbreviating it so it's not misconstrued. As I said in tutorial 1, the main important thing is that it's clear, it's accurate, and it's factual, because it's a legal document. As I said before, I've completed patient report forms where the job has gone to coroner's court 5 years later, not to do with us, the paramedics, but we needed to give evidence. And if I don't complete my report form, then one, it will be picked up on auditing if it's really poor. And two, anytime I need it to give evidence, if I've written just a few lines, I'm not going to remember what job I attended a year ago or 5 years ago. So please make sure that you take a lot of time and effort to, when you do a thorough assessment, that you record it and you record what you found and what you haven't as well. All right, I look forward to reading some of your case sheets, and like I said, don't hesitate to contact me if you need any further clarity on anything. Thank you.